Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Welcoming Dr. Raquel Zita Gomes from Portugal for the fourth session of the day at the Academy of Oral Surgery, Podinars. Welcome, Dr. Zita. How are you?
Hello, how are you?
We
Good
really
afternoon
appreciate.
from Portugal.
Yeah, the European side is starting to get dig into your afternoon on a Saturday. We appreciate your time for coming on and bringing some valuable knowledge for our colleagues.
You're welcome.
You have a very interesting topic of the atrophic maxilla, something we all struggle with. And it'll be very exciting to see the information that you have that might complement what Dr. Dietrich lectured about and others. But before we get into the technicalities and the scientific presentation, I would like to do a quick housekeeping agenda and then introduce Dr. Gomes a little bit more in detail and discuss her credentials. First and foremost, guys, I'm going to share my screen here so we can all look at the different scenarios. At the end of the lecture, when Dr. Zita is done performing the lecture, you will find a section on the right side in the chat box where you can go ahead and register for your 1 CE units. It's AGD PACE, and there's a process for doing that. It's complimentary to watch. More importantly, I wanted to let you guys know that if you're participating today at this event or kickoff for the Global Podinar Series, which started today, and it commences every weekend, and there's CE units available every weekend that you can register for to meet your requirements wherever you might be. But also as a token of appreciation and the deep-rooted relationship we have as doctors, we live similar lives. We lead similar everything, really, from patient care to families and whatnot. So we started this D2D, doctor to doctor platform to enable our colleagues and only our colleagues. This is a complete elimination of third parties in the equation. So help us expand the doctor to doctor movement and regaining our patient doctor relationship back and restoring that to what we love the most is educating another. Last but not least, I wanted to let you guys know that if you wanted to get involved with the workshops that we're starting back up, you're free to register. For those that are watching today, we have a discount of 50% for the upcoming ones that we are doing now with Dr. Wiedemann, who lectured earlier today. We've been doing these workshops since 2013, and they're very well received by our GP and specialty colleagues. And that leads to the last topic on how do you get involved with Podinars. First, in order to get on a Podinar, you have to become a part of the world's doctor-to-doctor top 100 that we have instituted a few years ago. And what we asked for this year, our nominations have skyrocketed. But if you have any doctor, medical, pharmacy, optometry, chiropractic, or dentist that you would like to nominate, or yourself, we would appreciate if you go in under the top100doc.com page. There's a lot to see there, a magazine. You can book Podinars with us if you like. If you have a service, product, technique, something that other doctors may benefit from so they can subsequently care for their patients, please book a Podinar with us and continue the nomination process. Please, a little less on the dental side. We're swamped with dental nominations. We have just expanded into medicine, optometry, pharmacy, and chiropractic. Please send us your friends and colleagues in there as we duplicate this model that has shown tremendous success over the course of the last 3 years into other healthcare sectors, because we're all doctors and we can all learn from one another. And we would like to have you guys on our system and participating with us. With that said, Dr. Zita is a very unique professional, loved by all, kind to all, and she started out of nowhere and came to a storm of the oral surgery and dentistry world with her tens of thousands of followers and all the doctors that she has trained over the years. And we are very honored to not only have her as a lecturer here, but also as an ambassador and a regent. For the longest time, she was the only female regent of the Global Summits Institute, and we are very grateful to have her back with us. Dr. Gomes, can you please tell us what motivates you to become the person that you are today?
Basically, I think it's about passion for your profession, passion for teaching, and passion for sharing. I think that's my main motive for being where I am today. Of course, you have to have a hard work to get to a certain level. You have to study hard and practice, but mainly, I think you have to have a big passion for what you do, and that will pass through to the others.
You're like the purple cow person that stands out in a big crowd. You're a female, you're an oral surgeon. What would you say to our female colleagues? As you know, more and more females are coming into the industry, and the Global Summits Institute is very fond of supporting this movement that you're part of. What would you say to other female colleagues that want to get into the oral surgery space? Because that one particularly is not heavily occupied. You know, we have clinicians like yourself and Dr. Arad and similar Schwarz Arad and similar, but there's not that many oral surgeons running around that are female colleagues. More on the cosmetic and other prosthetics, but not oral surgery. What would you say to them?
I will say, if you really love surgery and you have a passion for surgery, please work hard and show your work, not only in magazines and scientific programs, in conferences, in social media. Show your work, because if you don't show it, no one will know it. And then with the hard time, you'll get there. Of course, I'm not saying it's easy for a woman. It's not, because many times we are mothers, and we have other things to deal with life, like men, but women are more
Like
focused on motherhood. But if you work hard, and if you show your work, and the doors will start opening, and then you have to show what you're worth it. And but it takes a little bit of time. It takes a little bit of persistence. I'm not saying differently, because you have to combine between being a mother, a professional, a wife, sometimes an entrepreneur, and then a lecturer. And so it's not so easy to represent all of this. But I think when you really want something and you really work hard on it, you will get the chances to be what you want to be.
Well, I'm personally very proud to know you. I've learned a lot from your surgical videos and things that you post online. And I hope many of our colleagues will come and see you here at Group Follow the Red or at the Global Summits Institute, where we can all learn more from Dr. Zita. With that said, I won't hold you up anymore. I'm very excited to learn about management of the atrophic ridges. So with that said, you have the floor, Dr. Zita.
Thank you. Thank you so much. So I will start my presentation. Let me just share here. Okay, I think I can start. So hello, everyone. I think we have doctors from all around the world assisting. It's a big pleasure to be here at Academy of Oral Surgery, and I hope you will enjoy my lecture for today. Today, my topic will be implant treatment options for atrophic maxilla. So I will start where I am from. I'm from a beautiful country in Europe with beautiful landscapes, beaches, castles, rivers. And if you don't know already where I'm from, you will know in this slide. So I'm from the country of Cristiano Ronaldo. So I'm from Portugal. We are actually the European champions of football, and I'm very proud of it. I like football. And I'm from a city in the north of Portugal, that is Oporto City, that is very well known by the Oporto wine, and is a very, very beautiful and picturesque city. You should come. And I told you a little bit where I came from. I'm going to tell you a little bit who I am. As Kianor said, it's not so easy to be a woman in a men's world. And I started to empower some movements, also defending women in dentistry and supporting women in dentistry. One of them is called Divas in Dentistry. It was founded by Delia Tuttle. And there's also other events and other associations that are trying to build more conditions for women to strive on dental profession, namely on the surgical fields. And this is a small video showing a little bit who I am.
So I want you to please help me welcome the next speaker from Portugal, Raquel.
My contacts, and I really hope that we can start moving again to presential education programs. Also, I like to start my presentation saying that I have some collaborations with some faculties, with some education platforms, with some brands, and I always choose this in the best interest for me and for my patients. So this is just to people understand that I have this kind of collaborations internationally. So where should we start? We should start going back to the basics and give some informations so you can then apply these informations and how to take the decisions about the clinical case that I'm going to present and how did I make my treatment plan. So when we talk about loading protocols, we can have immediate loading, early loading, or delay. And what are the criteria, the main criteria to decide between these three different protocols? It's the ISQ, that stands for implant stability quotient, the torque, and the bone density. So as we know, immediate loading, it doesn't mean that it's in the exact hour or exact day. It can be until 48 to 72 hours after placement. Early loading, it's between 48 hours to 12 weeks, and delay after 3 or more months. We know that there are several ways to measure the primary stability. Some of them are subjective. We are going to focus on two that are very objective, that is the torque and the ISQ, implant stability quotient. So we know that the torque measures the rotational stability, and we can only measure it once. But the ISQ measures the vibrational stability or axial stability, and we can measure it several times, not only in the implant placement, after during the healing, and even after a few years of being rehabilitated. So what is ISQ? The ISQ is a scale of stability. It goes from 1 to 100, and it uses resonance frequency analysis to measure this stability. And the acceptance stability will be between 55 and 85. And we know if the ISQ is very high at the beginning, it tends to go a little bit flat with time. If it's very low, it starts to go up with time. And if it quick drop, it goes quicker down, it means that we have a problem. And how do we measure this implant stability? So we have a smart peg, that is a tip that we put on the implant, we screw on the implant. It has to be between 8 to 10 newtons. And then we use an apparatus of radio frequency analysis that the original one is Hostel, and then we have some other ones that were developed after to measure this vibration. And it gives you a number. The normal behavior of ISQ with time is you start with a number, and then you have a decrease between 3 to 4 weeks, and then it starts to go rising again. Why? Because first we have mechanical stability, and then after a few weeks, we'll start to have the biological stability. So this transition, sometimes you have a break between one and the other. So this is what was normally described in the literature. So you have a break between the first month of the healing. But because I'm very curious, we did some research about the implant stability in the worst case scenario, the posterior maxilla. And we did a controlled clinical trial. We compared 3 groups, one of the healed side, another one with bone generation at the same time, till 50% of the implant, and then another one that we didn't have bone enough, so we did sinus lift prior, and then we wait for a few months, and then we put the implant. And the results were quite impressive because we were expecting the break between the first months, and we didn't have that. Of course, these results, they were published already a few years ago. They are explained not only because of the type of implant, the design of the implant that we used in the study, but of course also by the protocol of preparation of the posterior maxilla. But it's very interesting because it goes against what it was in the literature before we published this article. And why should we have these guidelines why is it important to have the ISQ and the torque? It's like a traffic light. If you have like a measure, it will guide you to have an immediate loading or a yearly loading or delay loading. So if you have a measure that will be the red light, that means that the ISQ is lower than 60, you should put a cover screw and not do any kind of load in the implant. If you have the red light, that means that the ISQ is between 60 and 70, you should put a healing abutment. So you can put some charge in the implant, but not an immediate loading. And if you have more than 70, if you are splitting the implants, or 72 if you are using a single implant, we have the green light and we can do immediate loading. So I'm going to explain how does it work. So basically, if we have to resume this, when we have the general guidelines for loading for single implants, if we have less than 30 Newton centimeters and ISQ less than 60, we should submerge the implant and use a cover screw. So we will do a 2 surgical stages protocol. If you have torque more than 30 and less than 45, and ISQ between 60 and 70, we can do immediate exposure with healing abutment, and we call it 1 surgical stage protocol. And then when you have torque more than 35 and ISQ more than 72, we can perform immediate loading with no problem. And we call it immediate restoration. Of course, if we follow these guidelines, we are sure that we are using scientific measures that were studied by many people. So these are not only my experience, but it's based on more than 1,000 articles about the ISQ. If we go for multiple, the threshold will be a little bit less because we are working together, so we are splitting the implants, so the torque can be a little bit lower. So the lower limit of torque will be less than 25 and ISQ less than 60, we put cover screw. The torque more than 45 but less than 40 and ISQ between 60 and 70, healing abutment. And torque more than 40 and ISQ more than 70 instead of 72, we can perform immediate loading. What about the bone density? We talked that the main factors to take the decision if you do which type of protocol we'll do. We talk about the ISQ, the torque, and the bone density. And the bone density classification, we know that the old school classifications are very not very objective. So they are very subjective. And they are very good, but many times you only know the quality of bone when you go to the surgery. So nowadays we have a new classification that you can use pre-operative. You can study the CDCT or the TC and use a program that will give you the MISH classification of bone density in Hounsfield's units. And we have the MISH classification between D1 and D5, and is much more objective measure. And you can predict something to your surgery. So we also did some studies about this topic, and we compare and try to have a relation between the ISQ at implant placement, the torque, and the CDCT bone density before placing the implant. And we found a linear correlation and a positive correlation. And we even made an equation by linear regression that we can find the ISQ if we had a torque. Of course, this is only valuable for this kind of implants that were knife thread implants, and only for 74% of the cases. We also published this article. If anyone is interested in having these articles, you can send the emails to the chat, and I can send the articles by email. So let's, now that we went to basic, let's talk a little bit about the simpler classification of insufficient ridges. I'm going to talk in general terms, and then I'm going to focus on the superior maxilla. So when we have a socket, we can do immediate placement or socket preservation. If we have a low ridge, the ways to solve this can be short implant, tilted implant, the traditional JBR, guided bone generation blocks, trespass of the nerve, lateralization or transposition of the nerve. When you have a thin ridge, you can do the ridge pleats, the GBR, like the social technique by Eastern Urban, tie mesh, mini implants, or palatal approach that I'm going to explain a little bit further. And we have a maxillary sinus that is very pneumatized. We can do crest or lateral approach for doing a graft. We can do tilted implants and avoid the sinus, or we can do different type of anchorage with zygomatic implants. And I even copy this slide from the presentation that Dr. Henry Didier did today, because he talked about pterygoid implants that are also an option of dealing with atrophic maxilla. As he said, we can increase the bone volume, and we can do with autologous or synthetic bone. Nowadays, I use more and more the synthetic bone, because if you are in a sinus, you have a cavity that is all surrounded by bone or membrane that is osteogenic. So basically, anything that you put there will work. And then we have the adapting to the patient's bone volume, like size, shape, site. Operative protocols, like I said, like the palatal approach, for instance. And of course, we have this type of implants, and I'm going to add to these ones also the mini implants. Show must go on! Show must go on! So the show must go on, and we'll start with the clinical cases and how to apply these information that I said prior. So let's show a clinical case that we did bilateral sinus Lucen's healing, and we use six straight implants on the upper jaw. As you can see, the maxilla is very atrophic. We have pathology on the first molars that are there. That molars were going to be extracted. The patient has epilepsy and has difficulty in retaining the temporary prosthesis. So we did a different approach. So we tried to do the sinus lift, maintaining temporarily these molars, and then we only extract the molars when we did the implant placement. We use some low-level laser therapy at discontamination. I'm going to explain the principle, and some plasma-rich fiber PRF also. I'm going to describe the clinical case. This is the initial status. As you can see here, I'm doing a different approach of the traditional one. So I'm going to maintain temporary these tooth, the 1/6, that has pathology. I'm going to do an approach a little bit upper to the sinus. As you can see here, there were no damage in the membrane. And here you can see we can elevate the membrane. You can see here the movement when the patient is breathing. And here we are using some collagen fleet from Osteobiol, and then some biomaterial that is a xenograft, porcine xenograft with collagen together, that is MP3 by Osteobiol. And on the top, I use some putty biomaterial that constitution is the same as the MP3, is also porcine xenograft. But the consistency is different and helps like sealing the window, and helps even gluing the membrane that I'm going to put on top. So I'm using a collagen membrane cross-linked by that is made by pericardium of horse, and a suture with supramute sutures, and I removed the suture in this case after 10 days. And you can see immediately the post-op X-ray. On the other side, we did exactly the same thing, so I'm not going to show the procedure. Technically, everything went okay. There were no complications, no complaints. But after 6 months of healing, we decided to remove the tooth that were hopeless, the 16 and 26, and put the implants. But we had a surprise that one of the sinus was well healed, but the other sinus was not. And I'm going to show how we deal it with the situation. So this, after the healing of the sinus, we know that we're going to extract these two teeth. We're going to maintain temporarily the 1/7 because it's important for proprioception and to establish the vertical dimension. The incision, we start to expose everything. As you can see, the crest is very thin on the front. We have like it looks like a blade. So here we have the option or to build with a big regeneration, to wait for a few months, or to do a different thing that we call palatal approach. So we go, instead of going in the crest, we go palatal, that the bone is harder, and I'm going to show how it works and some articles published about this subject. And because the treatment plan was for an ivory situation, the compensation of the lack of bone was made with the prosthesis. So as you can see here, we are cleaning everything, the bone is not good, and in the second quadrant we had a problem. So we had a failure sinus graft. So in these cases, we have to clean everything, all the membrane that is affected, all the soft tissue, and we get a black hole. And then as a protocol, I use some laser therapy, low-level laser therapy, to do the contamination of the healing site. I use a dye that is a blue dye, and then that stains bacteria, and then I use the laser, the red laser 660, to activate this dye and burst, kill the bacteria. This is the principle of the low-level laser therapy as antimicrobial photodynamic therapy. And as you can see, this is a procedure that can be done in several applications in dentistry, and the principle of killing the bacteria is oxyreduction. This is a small video showing how it works. It's not only for bacteria, it also works in virus and in fungus. So it can be used in herpes or candida, and it also helps stimulate the healing because of the red light. And the great advantage of this photodynamic therapy is that is an antibiotic therapy that is local, doesn't have the side effects of being systemic, and has less chances of having resistances, and has a lot of applications, as you can see. So when we compare like traditional antibiotic with the antimicrobial photodynamic therapy, basically the APT is more local, has no side effects, no resistance, and no lack of action. As we know, the systemic antibiotics is systemic, has some side effects, and sometimes resistance and lack of effectiveness. And continuing in the case, so we used antimicrobial photodynamic therapy in both of the sites, because we had pathology also on the teeth that we removed, and on inside the sinus that was a failure. The other sign was okay. We did palatal approach. The implants used were Bread and Tool Sky. As you can see, the torques were not very high, between 20 and 25, 15, and we did the palatal approach, as you can see here. And then we have to deal also to see the stability that was medium, not very high, because the condition is not very good, but of course, in this case, I'm going to put cover screw and avoid the force in the implants. And then I have to deal with the problem. I managed to put the implant on the second quadrant, on the septum of the tooth that I extracted, but I have a big hole and I need to do some regeneration and to fix the membrane there. So what did I do? So my idea was to suture the membrane that was quite dense to the wall of the sinus. As you can see here, I use like some resorbable suture, Vicryl Rapid, and I sutured the membrane to the wall. This stabilized the membrane, and then I put some collagen membrane on top. I use some PRF also to stimulate the healing, in this case APRF, and some collagen membrane that is a little bit more rigid, cross-linked, that will be there for about 4 to 6 months to stabilize. And then, of course, I use some xenograft together with some PRF. And then I had to deal also with the other implants to do some regeneration. In this case, because I did the palatal approach, I'm going to do the regeneration in palatal and not in vestibular. Okay, traditional regeneration with bone grafts and the collagen membrane. And then we're closing everything with Supramid 4 zeros. We remove the suture 15 days after. It's after 1 month, after 6 months. In the day of the surgery, of course, because we closed everything, we used the traditional procedures that had the patient. We had the 2 tooth that we extracted, and we put some soft reliner. And this is the X-ray immediately after surgery. So 6 straight implants and the regeneration of the failed sinus in the second quadrant. In the first quadrant, the sinus was well healed, and palatal approach. And then after a few months, we did the final metalloacrylic cerulean rehabilitation. Of course, this is a teamwork. Normally, in some clinics, I basically do the surgery, and I have a team that does the restorative. This is also a clinical case of bilateral sinus lift, showing like the steps of the sinus lift that are normally very well succeeded, and a more basic case, not the same that the one before. Another clinical case showing other option in also very atrophic jaws. You can see very thin ridge, low and thin. So it's a female, 70 years old, with osteoporosis. She didn't want to do big procedures of regeneration or waiting, or even by economic terms. So the chances and the option that we thought was putting 4 mini implants for an overdenture. And we also are using the palatal approach, as I said before, because we have a very thin ridge, and we are going to do some kind of trespass of the sinus by palatal. It's more or less the principles of the pterygoid implants, but a little bit more to the front. So we are trespassing some situations to give a good anchorage to the implants. As you can see here, we used 4 mini implants by Bredent, 2.8 by 11.5 by palatal approach. The torque was 25 ISQ around 59. So we decided to cover everything and to put the cover screws and wait. And then after a few days, we removed the suture. We waited for 3 months, and then we did the second stage surgery, and then the ISQ was 70 or more in all the implants. We did a traditional pickup open tray impression, and we did like 4 mini locators that are specific of this system, and we did an overdenture. This is before, and this is after. So sometimes it's easier to go for small implants or short implants or very thin implants and avoid big regenerations. And this is was one article that I published a few months ago about the palatal approach in Edit Journal. It's another case, not the one that I showed here, but interesting one also. Showing that the results of these cases, even with long-term follow-up, are quite stable and quite good. So we have here one more clinical case. This time the approach is going to be a little bit different. So I'm going to do what we call fast and fix concept or all-on-4 concept. These tools are hopeless. We're going to extract in the same day. As you can see, the sinuses are quite pneumatized in both sides. The patient is a heavy smoker and have severe periodontal disease. And he didn't want to do like big procedures of regeneration, and he didn't have indication also. Because he had sinusitis and heavy smoker. And the treatment plan was to do extraction, the low-level therapy, the fast fix concept. I'm going to focus on the upper because it's the topic of this lecture. And in this case, I managed to do immediate loading because I had the perfect conditions to do so. So this is the initial status. I'm going to focus on the upper. As you can see, we have a big defect on the 21, 22, 23 area because we had a cyst there. And so there we go a little bit palatal, the approach, because this is going to be an hybrid situation. On the posterior ones, we have to deal with the big angulation of the sinus. First, we do decontamination of everything with low-level laser therapy. This is the blue dye that we put before. We maintain it for 1 to 2 minutes, then we rinse it with saline to remove the excess, and then we apply the laser, the red laser, to kill the bacteria. And we are applying the elbow blue. And here we are putting the angled, tilted implants on the distal part, the concept of all-on-4, and we go parallel to the wall of the sinus. This is a concept that is well studied and well published in the literature, and it works quite well. Of course, you should use long implants and not very straight ones, because the risk of fracturing these implants with the cantilevers is big. So there's some rules to do this technique. Normally, we put implants of 14 or more in length and at least 4 millimeters of diameter implants. As you can see here, we are putting first distal ones, And then the anterior one will be like a post-extractional in the site of the extraction of 1-2. And then the other one will be palatal approach because we don't have bone on that site. As you can see here, the implants are 16 or 14, 12 in length. We are trying to do bicortical anchorage for good primary stability. The torque was quite high in all of them, 50 Newton centimeter. We are putting also the final abutments, okay, the multi-annual abutments with angulation, and the ISQ measures were quite high, between 85 and 87. The minimum that we had was 75, the maximum 87, but in overall terms is quite high. So we can do immediate loading because we have the minimal torque and the minimal ISQ to do immediate loading in a full arch. Then we do some regeneration with xenograft and some collagen membranes, suture with Supramid 4.0, and we use the concept one abutment one time that is to try to train the bone and save the tissue. Of course, this is the ideal situation if you can maintain already the final abutments and not touching the implant anymore, just touching the abutment level. This will be the ideal situation. Of course, if you have some retraction, you can change in the future the abutment, but ideally it should be like this. And of course, the implant, the patient comes in the morning, and then the lab technician comes to help doing the pickups and do the polishing in the laboratory, and goes like this in the afternoon. These are the provisionals. As you can see, the upper ones, the distal ones are quite tilted. They are more than 45 degrees because in this system we have the right abutments to correct this angulation. So be careful not to use very high angles if you don't have the correct abutments to correct it. This brand, that is Bredent, has this kind of abutment that allows us to do this kind of position of the implants. Of course, not always things go well, and as I saw in the first case, we had some failed sinus, and now I'm going to show also a complication of a failed sinus with oral and trial communication that was tried to be solved with different techniques, but was not enough. So the final approach, and the one that really managed to this situation, was to use the Bischoff fat pad to cover this oral and trial communication. And this patient is female and has lichen planus, so the mucosa and the gingiva is quite thin and quite friable. So it was a little bit difficult to manage the situation. So this was the initial sinus lift, the first X-ray, and then it failed. We have to clean everything, and then in the second surgery, we managed to put the implant a little bit distally, and we didn't did the sinus again, and we tried to close. But at the beginning, we didn't manage to close at the first time. So the second time, we had this kind of oral tract communication, and our idea was to use the buccal fat pad that is elastic to cover this communication, to use some plasma inside, and to use the Bischoff fat pad outside. So that was what we did. We clean everything, as I said before. When we have this kind of product, we have to clean everything. We use some topic antibiotic. At this time, I didn't use the elbow, because this case is a case that is older than that. So I used some topic antibiotic, tetracycline. And after cleaning everything, we prepared some plasma-rich fibrin from the blood of the patient, and we put some plugs inside the sinus to stimulate the healing from inside out. And then we pick up the Visha fat pad and we pull it to the front, and we use some sutures, some of them resorbable, some of them not, to stabilize the Visha fat pad. The great idea of this concept and the success is mainly because you maintain the vascularization of the fat pad. You don't cut the Visha fat pad. You maintain the vascularization distally, so you maintain all the irrigation to the fat pad. And after stabilizing with sutures, and then you close everything on top. And then you can see here after 1 month and after 6 months. And this case has already more than 5 years and is quite stable. So let's jump into conclusions. Does anybody know what we are looking for? At least when I go to a lecture, I'd like to have simple take-home messages. So I'm trying to resume this in my conclusions. So a general conclusion, we know that nowadays, with new technologies and techniques, we can practice implantology in a more efficient, faster, and safer way. Also, as we told at the beginning, when we talk about the basics, we know that the torque measures the rotational stability only once. The ISQ measures the axial stability and can be measured several times, even during the healing period and after. The bone density can be measured before going to surgery objectively on the TC or the CBCT in Hounsfield's unit in the MISH classification. When we use single implants, the rules for immediate loading should be for any system of implants, ideally torque more than 45, ISQ more than 72. And for multiple implants, like I showed with the ballerinas, if they are together, the values can be a little bit down. So the immediate loading can be with torque more than 40 and ISQ more than 70. And I showed here some techniques. Of course, it's not possible in 45 minutes to show all the techniques to deal with the atrophic maxilla, but it was good that Dr. Didier talked today also and show other possibilities. But good techniques to deal with the atrophic maxilla are the palatal approach, the open sinus lift and healing, the automatic sinus lift, the tilted implants, the trispas of the implants of the sinus, the mini implants, and of course there's other options like the pterygoid implants or the zygomatic implants. Another final message. If you don't leave your comfort zone, the magic will not happen. So sometimes, of course, you have to be have conscience of what you're doing, to have the proper education, and we are here to try to help you to have the proper education. But sometimes you have to risk a little bit and to try some new solutions and to try to do something different and to try to help your patients in a certain way. So when you try this, even when things go wrong, you learn with your own mistakes. You're smart, of course, and then in the next time you will do better and you will learn and pass your experience to other colleagues. These are my contacts on LinkedIn, on Instagram. This is my private email if someone will need some help or some articles. I also have a Facebook group called Follow the Red that is dedicated to oral surgery. So it's free to enter, and we share not only lectures, we share cases, we share articles, we share experience. So if you're interested to join, please ask to the group, and me as an admin, I will accept. So thank you for everything. I think I managed to do my time correctly, 45 minutes. And I'm here open to answer the questions if you have some. Thank you.
Dr. Gomes, Dr. Zita, thank you so much for this wonderful presentation. I've been watching your presentations for many years. Unfortunately, due to the time restraints that we have, we're asking folks to leave comments and messages and questions in the chat box. So I would kindly really appreciate if you go in afterwards and actually look at those and and uh, answer those. I personally had a quick question for you. When you're doing the palatal approach, do you have any kind of recommendations for people that want to attempt it? Because the anatomy is somewhat not very familiar to us, besides the greater palatine bundle that comes out of there in the back.
Normally, when you do the palatal approach, you normally do it in the anterior zone. Of course, sometimes you go a little bit back, but normally in the anterior zone that you have, the crest is more thin. You have to go, of course, parallel to the crest. So ideally, you should expose the vestibular part of the crest and go parallel to that, because you will have a very primary good stability, because you will have an anchorage on cortical bone. And ideally, if you can manage to do bicortical anchorage in the nasal floor or in the floor of the sinus, that will be even greater, because you have more primary stability. In the back part, of course, you can't go too distally because of the greater palatine artery. But if you go in front and you are sure that you are or trespassing the sinus or having bone in height but not in width, you can go palatal and have a very good primary anchorage. And also it helps with the rehabilitation, because it gives you the access of the screw more palatal. So it's even easier to do the rehabilitation, because sometimes when you have very thin crests and you put it on the crest, the implants are very outside the limit of the prosthesis, and you have to compensate with angulated and abutments, and sometimes it's not so easy to do the rehabilitation. So even this, it's easier when you do the palatal approach.
I see. So you mentioned, I mentioned the greater palatine, and in the anterior palatine, some have also suggested to scoop it out of the anatomy to place an implant there. What's your take of encroaching up on the from the palatal side on the front extension of the greater palatine?
Okay, of course you have to know the limits, and you have to know the localization anatomic. Normally the greater palatine, the distal one, are on the second molar. Of course, if you are removing doing the, how can I say, the flap elevation on the palatal, you should go always with bone contact and avoid going a little bit too much distally. So go to first molar, not more than that. Look at the CVCT, because you can localize the arteria there, and of course guide your surgery in terms of your X-ray. In the anterior zone, in the nasopalatine nerve, sometimes we even, when we need, sometimes we even cut incisive nerve, and we remove the nerve and do some grafts there when we don't have any options of dealing with the situation. Normally, we avoid, of course, and we know that the nasopalatine nerve and hole has normally heart shape. So even if it's very narrow on the palatal, normally upper it goes wider. So be careful with that, because if you go with the implant, it's not a problem about the nerve. It's the problem is if you maintain the nerve and you put the implant inside the nerve, probably you will have soft tissue integration and the implant will not work. So in that case, if you don't have any chances, you remove the nerve and you graft the nasopalatine hole.
Very cool. Very cool. I kind of asked you that too, because a lot of times when we're placing anterior implants, especially on 8 and 9, we tend to get close to that area, and sometimes it ends up causing problems. Anyway, Doc, I gotta tell you, you took the day with over 250 shares by our colleagues. Everyone loves Dr. Zita. I wanted to personally thank you for coming in, and wanted to let the rest of our viewers also know that, again, you're welcome to register for CE form. Something just popped up into the chat box where you can follow the instructions there to obtain your CE. And also, as colleagues, we'd like to really, really kindly ask you to help us to continue to grow our platform, which is reliant upon referrals from you, from doctors. Our contention is that the doctor-to-doctor movement and collaboration is the only sustainable way for a broken healthcare system around the world. So nomination is there. We're looking for more MDs, more pharmacists, more optometrists, and more chiropractors. We are very overwhelmed with the dental category that was started 2 years ago. Continue sending them to us. You have ideas, concepts, techniques, just like Dr. Zita just presented many techniques that you can use in your clinic practice. Let's bring that information to our colleagues without any barriers to trade, without any steps to register and go to conferences. They can just simply tune in and gather this information that they need. So book your Podinars here, nominate more doctors. Let's continue expanding this concept across the world and reaching millions of our colleagues. Again, Dr. Zita, I would like to thank you on behalf of our colleagues for donating your time on a Saturday to bring us all this knowledge and information.
You are welcome. I'm very glad to be here.
Wishing you a wonderful day, and you can see more from a doctor based on the information that she's provided in terms of her personal contact, as well as all of the countless organizations Dr. Zita has affiliation with. Thank you again, and enjoy the rest of your weekend, doctor.
Thank you. Bye-bye.
Bye. We'll see you guys for the last final show in approximately 10 minutes. Thank you.
Thank you.